You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City. Today is October 17th, 2025. We will be doing our fellows presentations, doing board review questions with Dr. Cody Shopper, an allergy and immunology fellow at Children's Mercy Hospital in UMKC.
All right, so first question. A 12-year-old girl with a history of peanut allergy, allergic rhinitis with sensitization to dust mite in grass, and atopic dermatitis presents for evaluation of possible asthma. You are calculating her modified asthma predictive index to determine her likelihood of persistent asthma. Which one of major criteria is used in this tool? Allergic sensitization to at least one arrow allergen, parental history of atopic dermatitis, physician diagnosed GERD, or 2 or more wheezing episodes. And anybody's free to answer.
Go with
No, not B.
2 or more wheezing episodes.
Like, sorry, I
Hello?
couldn't hear you, but not B or C, I don't think. And then I don't think 2 or more wheezing episodes is used in the criteria. I'd go with A.
I was also leaning towards A.
Okay, Matt said A. Okay. All right, so yeah, correct answer is A, allergic sensitization to at least one arrow allergen. So modified asthma predictive index, this is identifying preschool age children that are going to be at high risk for developing persistent asthma as they grow up. It's used primarily in children who have recurrent wheezing. So this was made from children younger than 3 years old with more than 4 episodes of wheezing in the last year, and that was one of them had to be confirmed by a clinician. So the major criteria: parental history of asthma, physician diagnosed eczema, and then sensitization to at least one arrow allergen. And then minor criteria: sensitization to food allergens, 4% or higher peripheral blood eosinophilia, and wheezing apart from colds. And so you have to have 1 or more major criteria or 2 or more minor criteria. And then the child has to have 4 or more episodes of recurrent wheezing. Clinically, has a very high negative predictive value, but just moderate sensitivity, so about 16 to 30%. And then a positive modified asthma predictive index will be strongly suggestive of persistent asthma, and negative is going to suggest a very low likelihood of persistent asthma. In practice, this is help make guideline decisions about preventative therapy, counsel parents about prognosis, and then also used in research and for guidelines as well. Question number 2. So a positive methacholine challenge is diagnostic of asthma. In a current patient, recent testing shows a fall in FEV1 from baseline after standard doses of methacholine. What percentage of change confirms the diagnosis of asthma after testing? 5% or higher, 10% or higher, 15% or higher, or 20% or higher?
Uh, 20% D.
And then Matt and Cheyenne, what do you guys think?
I'd also go with 20%.
Good idea. Follow your second year fellow. Yes, 20% is correct.
Yeah, I was about to say, I don't think I would contradict Manali.
So, methacholine challenge. So, what we're assessing is airway hyperresponsiveness when the diagnosis of asthma is uncertain or wants to be completely ruled out. So, methacholine, what is it? It's a nonspecific M3 receptor agonist that causes bronchoconstriction. So, patients with asthma will respond to lower doses compared to the normal population. How it works: so it's inhaled methacholine given in increasing concentrations via nebulizer, and then FEV1 is measured after each dose, and the test is stopped once you get a 20% or more decrease in the FEV1 and a methacholine concentration of 8 milligrams per ml or less. High sensitivity, so it's really good in ruling out asthma if negative, but it's also not as specific, so it can be positive in other conditions, and people with COPD, allergic rhinitis, smokers if they're sick. Contraindications, so if they already have an FEV1 below 50%, if you're trying to provoke bronchoconstriction, you could cause a lot of harm. So you want that to be above 50. If they've had a recent MI or stroke, they have uncontrolled hypertension or aortic aneurysm, and then if they're pregnant, those are also going to be contraindications to doing methacholine challenge. Prior to the methacholine challenge, they have to hold SABAs 8 hours or more, long-acting beta agonists 2 days in advance. They have to avoid coffee in the morning or caffeine, smoking, rigorous exercise before the test. And then once the test is done, then we'll give them an inhaled bronchodilator to reverse it. So, in summary, a negative test virtually rules out asthma. Positive test is not diagnostic and should be interpreted in the clinical context. There is a risk of false positives, as we just mentioned above, and then it's the gold standard for bronchial hyperreactivity, but it's not routinely needed if the clinical diagnosis is already clear and you're seeing reversibility on spirometry. All right, next question. So a 32-year-old non-smoking woman presents with a history of persistent asthma symptoms despite regular use of high-dose inhaled corticosteroids and bronchodilators. She reported nocturnal awakenings due to cough and wheeze, exacerbations triggered by environmental allergens, and a notable family history of atopic diseases. Physical exam revealed diffuse expiratory wheezing, and laboratory investigations demonstrated elevated eosinophil levels in peripheral blood and sputum. Which ILC2 produced effector cytokines are expected? Interferon gamma, TNF alpha, IL-4, 5, 9, 13, and amphiregulin, IL-17 alpha, and IL-22, or IL-25 and IL-33.
Is it C, 17A and 22?
And then Cheyenne and Manali. I know it's a wordy question, so take your guys' time for that one.
Yeah, I would go with B, with like innate lymphoid cells too. I think of those cytokines, but
I'd also go with B.
B is correct. So, group 2 innate lymphoid cells or type 2 innate lymphoid cells, these are a substate of innate immune cells that we have. Initially, mouse studies show high levels of IL-5 and IL-13 when these cells were stimulated by IL-25 and IL-33. And now we've also seen IL-4, IL-9, and amphiregulin be produced too. So the cytokine profile of type 2 innate lymphoid cells is very similar to the cytokines produced from Th2 cells. So anytime you're thinking about type 2 immune responses, think about these two types of cells that are stimulated. When it comes to what they're actually doing, so they're trying to promote clearance of helminth infections, and they'll also contribute to airway hyperresponsiveness like in asthma. All right, a clinical investigator searches for biomarkers that specifically identify human ILC2 in blood, GI, skin, BAL, nasal mucosa, and nasal polyps. He finds that human ILC2s are also CD45 positive lymphocytes that are negative for markers for T, B, and NK cells, as well as myeloid and granulocyte populations. In contrast to mice, human ILC2s are universally identified by positive surface expression of certain biomarkers. What are these biomarkers? CD16 and 19, CD45 and CD3, CRTH2 and CD161, TCR XD, and FC epsilon R1.
I'm not sure if
I don't know this one. I'd just be guessing. Yeah.
I think I actually don't know, but let's try to eliminate. So negative for markers for T, B, NK cells wouldn't be A because that has CD16 positive. Wouldn't be B because that's CD3 positive. So I'd narrow it down between C and D. But like D just sounds like like a T cell receptor and FC epsilon R1, and those are not biomarkers. So by process of elimination, I go with C, but I don't actually know.
I would also go with Manali's answer.
Beautiful job. That was great reasoning, and yes, not an easy question, but you can deduce it. And then if you just have a little background knowledge, you can get it. So that was a really good job. So human ILC2s, these are distinct from mice. They are CD45, CD3, 16, 19, 20, 14, 56. CD4 are all negative, and then they are CD161 and CRTH2 positive. And then other markers are also CD127, CD25, ICOS, and KLRG. And then CRTH2, it's also known as DP2, so you get another name to remember, and it's a prostaglandin type 2 receptor. All right, a 28-year-old woman with a known history of severe allergies, including anaphylaxis to aspirin, presents to the emergency department following an accidental ingestion of aspirin-containing medication. Within hours of ingestion, she develops generalized urticaria, facial swelling, and respiratory distress. Laboratory investigations reveal an elevated serum tryptase and a notable increase in group 2 innate lymphoid cells in peripheral blood, as one ER physician would do. Which mediators promote the activation of mast cells, basophils, and ILC2? Is it LXA4, myrisin-1, PGD2, and cysteine leukotrienes, prostaglandin E2, and PGI2?
This is largely a guess, but I'm leaning towards A.
Cheyenne, did you want to take a stab, or I can try to?
Yeah, LXA4 is lipoxin 4. Sorry, I should have put that.
Kind of just like what I talked about in the last lecture, but you definitely have cis-LT in there, and then PGE2 is anti-inflammatory, so would not promote activation, so I'd go with C.
C.
I don't think lipoxin does. Yeah, I'll stick with C.
Yep, it is C, PGD2 and cysteine leukotrienes. So, activated mast cells and basophils will release lipid mediators like prostaglandin D2 and cysteine leukotrienes. These further activate mast cells and basophils, amplifying the allergic response. And they'll also recruit and activate ILC2s, which have these receptors that we just talked about. And then activation of ILC2s, it does lead to the release of IL-5, 4, 13, and again, it's going to promote that type 2 inflammation and airway hyperreactivity as well. Lipoxin A4 is actually anti-inflammatory lipid mediator and will inhibit mast cell and eosinophil activation. Myrisin-1 is another specialized anti-inflammatory mediator that limits inflammation and promotes tissue repair. And then prostaglandin E2 and prostaglandin I2 are generally anti-inflammatory in allergic contexts and will suppress mast cell activation. In CD4 positive T cell activation and IL-2 production, two principal co-stimulatory molecules interact when a CD4 T cell contacts its specific antigen presented by class 2 MHC molecules on APCs. What are these two principal co-stimulatory molecules? A, CD28 on the APCs and CD8086 on the CD4 T cells. B, CD28 on the CD4 T cells and CD8086 on the APCs. And then C, CD8086 on the APCs and CD28 on the CD4 T cells, or D, CD8086 on the CD4 T cells and CD28 on the APCs.
Is it D? That'd be my guess.
Sorry, am I just misreading it, or like B and C saying the same thing? And then A and D are saying the same thing, or am I misreading that?
No, you're right. They are saying the
Okay.
same thing right there. CD8086 on the APCs and CD28 on the
Yeah, but just reversed.
Okay, yeah, just reversed.
You're
Okay.
totally right.
Makes it 50-50.
So yeah, I guess between A and D or B or C.
Okay. You said D. Man, a lot of immunology and biomarkers. I'm pretty sure. I'm forgetting these biomarkers. I'm pretty sure CD28, if I'm trying to remember from last year, I'm pretty sure that's on CD4 T cells. Yeah, I'll stick with my gut. So like either B or C, I guess.
So yeah, CD80, 86 on the APCs, and then CD28 on the CD4 T cells. So co-stimulatory signal is an interaction with CD28 on the CD4 T lymphocyte with either CD80, which is B7-1, or CD86, which is B7-2 on the antigen-presenting cell. And these signals will stimulate IL-2 production, which further induces CD4 T cell proliferation from naive T cells. All right, TBET promotes Th1 differentiation. Which protein does it inhibit? BCL6, FOXP3, GATA3, or ROR gamma T?
Is it D, the Th17 pathway?
Yeah, I was going between C and D because if TBET promotes Th1, that was nice of you to write which other markers are Th2 and Th17. But I'm pretty sure if TBET promotes Th1, then you would have inhibition of the Th2 pathway. Going between C and D. I'll go with C. Yeah.
Okay. Yeah, so GATA3 is correct answer. So IL-2 inducible T cell kinase will phosphorylate TBET, and this is a transcription factor that drives Th1 differentiation. That phosphorylated TBET then gains the ability to actually physically interact with GATA3, which is the key Th2 transcription factor, and that actually leads to sequestration of GATA3, thus inhibits its DNA binding activity and suppresses Th2 gene expression. So that tilts the balance toward Th1 response. Conversely, when it comes to developing Th2 cells, GATA3 will interact with what's called RUNX3. This is a transcription factor that normally cooperates with TBET. So once GATA3 is interacting with RUNX3, it prevents it from associating with TBET and blocks that cooperative activation of the interferon gamma gene, which is a hallmark Th1 cytokine. So it always ensures a balance between Th1 and Th2 pathways. So just to kind of summarize that. So inducible T cell kinase mediated TBET phosphorylation serves as kind of molecular switch, coordinating the cross inhibition between Th1 and Th2 lineage commitment for those cells. All right, so which of the following is true about innate lymphoid cells? A, their development occurs in the thymus. B, they are activated by specific antigens. They are derived from the common lymphoid progenitor with antigen receptors, or they play a role in mucosal homeostasis, inflammatory signaling, and wound repair.
Is it D?
Yeah, I would agree with Matt for D.
Good job, guys. Yes. So, previous studies of innate lymphoid cells suggested they may play an important role in a diverse set of processes like mucosal homeostasis, inflammatory signaling, and wound repair. And then we'll go through each one why they're incorrect. So, A, development does not occur in the thymus. It's going to occur in the fetal liver and the bone marrow after birth because these are the sites that will harbor the majority of common lymphoid progenitors and common helper ILC precursors. And then B is incorrect, so ILCs are activated by stress signals, microbial compounds, and just the general cytokine milieu in the surrounding tissue rather than by a specific antigen. And that also leads us into C because innate lymphoid cells do not actually have any antigen receptor at all, which is a key difference from normal T lymphocytes. Okay, what is required for the development of both Th2 cells and ILC2 cell types? GATA3, IL-25, TBET, or TSLP?
just kind of leaning on the question we did before this one, but is it A, GATA3?
I agree with A.
So, let's see. We already talked about the front one there. So, GATA3 is going to regulate the expression of Th2 cytokines, IL-4, IL-5, IL-13, and then we'll just I think there's more learning here why the other ones are wrong. So, IL-25, it's a cytokine that's going to activate or enhance ILC2 function, but it's not required for the development. TBET, we already talked about. And then TSLP, this is an epithelial-derived cytokine that stimulates type 2 responses, but will not actually drive any cell lineage commitment. Okay, which of the following transcription factors is upregulated during germinal center B cell development and is essential for the formation and maintenance of germinal centers? BLIMP1, BCL6, IRF4, and our old friend GATA3.
Is it C, IRF4?
See, okay.
I was going between A and B, and I'm actually not. I don't remember. I was gonna go with A though.
BLIMP1, okay. All right, so correct answer is B, BCL6. So BCL6 is a key transcriptional repressor that is upregulated in germinal center B cells. It's going to promote proliferation, somatic hypermutation, and class switch recombination by actually repressing genes involved in plasma cell differentiation and DNA damage responses. So BCL6 will suppress BLIMP1, which is responsible for driving plasma cell differentiation, which thus keeps the B cells in the germinal center stage. So BLIMP1, so that's going to be upregulated after B cells leave the germinal center, and again, it's going to promote the plasma cell differentiation. IRF4, this is initially going to be low in germinal center B cells, and then it will increase later to promote the exit and plasma cell development. And then GATA3, I'm done talking about that. We talked about it a lot. And then BCL6, so just a little thing you can say to yourself to maybe help remember. BCL6 builds the center, BLIMP1 breaks it down. Just a little mnemonic. Not a great mnemonic, but maybe you'll remember.
Solid, man, solid.
All right, I think this is the last question. So, a 52-year-old landscaper experienced anaphylaxis after multiple stings while mowing. Skin testing and serum IgE are positive for honeybee and yellow jacket. Component resolved diagnostic shows the following. So, our AppyM1 is positive, VESV51 is positive, VESV5 is negative. Cross-reactive carbohydrate determinants are negative. You are planning on starting venom immunotherapy for them. Which of the following is the most appropriate approach to venom selecting and mixing? A, treat with honeybee venom only, since the yellow jacket sensitization represents cross-reactivity. B, treat with yellow jacket venom only, as it provides partial cross-protection against honeybee venom. C, treat with a single mixed vespid extract, since they can be combined safely. D, treat with honeybee and yellow jacket venoms administered separately because their components are non-cross reactive and cannot be mixed in the same vial. Or E, treat with a combined honeybee and vespid mixture in a single vial as long as dosing is reduced. Another super wordy question, so take your guys' time.
I am not 100% sure about this. I think it'd be D. Don't think you can mix that. But I'm not sure.
Okay.
Okay, so sorry, it always takes me a while to go through these. The APM1 is positive, so that would be honeybee. VESV1 would be the vespid. The cross-reactivity is negative, so meaning it's like a true positive to venom, to like the vespid part of it, so the yellow jacket. Okay, so I agree with Matt, they can't be mixed in the same vial, because like all Vespids can be in one vial, but Honeybee and Yellow Jacket would have to be separate. Yeah, I think Matt said D.
Yeah, he said D.
Okay. I would agree with D.
Sharon, are you going D as well?
D as well.
D as well. Okay. Yeah, good job, guys. So, component resolved diagnostics helps distinguish true dual sensitization from cross-reactivity. So, our APM1 is phospholipase A2. Sharon and Matt, we do have to know the specific allergen with it. So, phospholipase A2, it's a honeybee-specific allergen. RVESP1 is phospholipase A1, and then RVESP5 is antigen 5. These are Vespid-specific allergens. The patient's pattern with the APM1, VESP1, negative CCD indicates true dual sensitization and not due to cross-reactive carbohydrate determinants. And so, mixing rules for VIT, so honeybee venom cannot be mixed with Vespid venoms in the same vial because of protein instability and potential degradation when combined. Vespid venom, so that's yellow jacket, yellow hornet, white-faced hornet, they are highly cross-reactive and they can be mixed safely in a mixed Vespid extract if needed. And then Polistis, or paper wasp venom, is less cross-reactive with other Vespids and usually requires a separate extract if indicated. And nice little table here, just kind of summarize that info there, what can be mixed, what are the key allergen markers, kind of just the same information that we already went over. And then that was my last slide. So any questions or anything you guys have, but everyone did a really good job.
Yeah, nice work, Cody. It's a great presentation. And you really got into the weeds with all the immunology side of it, but that's necessary, as you know, to get through your boards. And then I do appreciate everybody speaking aloud about their, kind of what to cross out, what answers are wrong. I think that's helpful for everybody to learn more than just the question answer, to learn what's not correct. So thanks for doing that.
Just one thing, the first question, I think the modified asthma score is used, or index is used for kids under the age of 3. So I'm not sure, because you said 12 years old, so I'm not sure that's applicable. But it's good, you have to know the modified asthma score. But used to predict or suggest the likelihood of developing asthma down the road if the patient has fill the criteria for the asthma predictive index or the modified asthma predictive index. The other one, the second question with the methacholine, usually, yes, definitely it's a good question to know the 20% change, but they will ask you what is the provoking dose. Like, definitely have to know it's below 8, because once you go 8 and above, then maybe it's unlikely to be positive. So they'd like to ask you about, if the patient had 20% decrease in FEV1 with methacholine, like adding a 2, 4, they give you a little bit of, they focus on the dose that you use, the provocation dose, more than the change. But it's good to know the change, definitely.
Yeah, I think we included the 8, and then the other thing too in the board review book, they also give 20, but it's a different units as far as the maximum provoking dose. But I can't remember the units off the top of my head. I don't know if you guys remember it.
Yeah, but should be, I think 8 is, the key is the 8. But once you go beyond that, it's just, it's not really positive. So they need to know, or they like the question, but because sometimes they give you a 20% change or decrease in FEV1 with 2, or the 20-10 with 8, or stay a little bit, try to mix it up and make it difficult for you. So we have to know the both criteria, that 20% and the dose has to be, provoking dose has to be less than 8. All right, yeah. Cool. Yeah, the last point, that's what you need to know.
Yeah, you'll see that likely on your boards.